Hello again, I'm Dr. Mark Trolice, Director of Fertility Care, the IVF Center. And today, as part of our video blog, we'd like to talk about the most advanced technology in the laboratory with an in vitro fertilization cycle called pre-implantation genetic diagnosis. Now, this is the umbrella term for two types of testing that can be done on embryos in the IVF laboratory. One is pre-implantation genetic diagnosis, or PGD, but the other is called pre-implantation genetic screening, or PGS. Now, we'll distinguish the two of those. PGD is where, firstly, the embryos are biopsied in the laboratory and then sent for analysis. So usually on day 5 of embryo development, several cells are removed from the outer part of the embryo that would eventually become the placenta, and that's called the trophector term. Several cells are removed and sent for analysis. With PGD, this is where single gene defects are able to be diagnosed, such as sickle cell anemia, or Tay-Sachs, or cystic fibrosis. And these are diseases that can be significant morbidity and/or mortality. So patients are sometimes discovered during their fertility evaluation or come in with a known genetic problem that they are a carrier, and/or their partner is also a carrier. And so the embryos are screened so as to avoid the genetic transmission to have an embryo and then child with the disease. The embryos are screened, and the ones that are affected are obviously not transferred, and the ones that are transferred would either be a carrier that would not cause harm and would be more like the patient, or one that is completely unaffected at all. Now, in contradistinction to PGD is PGS, and that's where the complete chromosomal analysis of the embryo is performed. So there are 23 pairs of chromosomes, 22 which are called autosomal, and then the sex chromosomes, XX for female and XY for male. So the complete karyotype of the embryo is done, and then normal chromosomal embryos are transferred back into the woman. This has been shown to significantly improve the implantation rate and reducing the miscarriage rate. Now, over the last several years, this technology has been studied and looked at as to what is the best day of embryo development to do the biopsy. Now, logistically, if the biopsy was done on day 3 and the embryos are analyzed, we would get the information back by the time day 5 develops. However, more recent evidence is showing that a day 3 biopsy actually can cause harm to the embryo, reducing embryo implantation. As a result, these biopsies appear to be best performed on day 5 of embryo development. However, unless the IVF center has the laboratory capability on site, the embryos that are biopsied need to be frozen and then await the results of the biopsy. The reason is because by the time the information comes back to the clinic, the embryo is not in good sync with the lining of the uterus. The embryo would then turn to day 6, and that doesn't seem to have good pregnancy rates. So when doing PGD or PGS, we recommend a day 5 biopsy of the embryos, then freezing the embryos, awaiting the genetic information, and then the following month, in a simple cycle of frozen embryo replacement, we thaw the embryo necessary to transfer, and the woman is placed on natural hormones to build up the lining of her uterus in preparation to receive the embryos. The method of freezing now is most advanced by using vitrification. And so the ability to transfer frozen embryos appears to be nearly as equal, if not even better sometimes, than fresh. So I hope this was able to explain some more information about the advances that we do with in vitro fertilization. And until next time, this is Dr. Mark Trolice.